Hi, this is Brian Kim. I'm going to share with you case number 104 in the best way to do cataract surgery series. This is a 2+ dense lens with a little bit of zonulopathy. And you're going to see double chop, cross chop, mechanical fracturing, and just the systematic way I address these challenging cases when there's a little bit of zonule weakness, being able to identify the zonular weakness, being able to leverage mechanical fracturing so I'm not going to cause any more zonular stress, in this case with a 2+ dense lens. So I'm going to use a cotton tip to straighten the eye, and then I'm using a corneal marker which will help me center and size the rhexis. Use a cotton tip to manipulate the eye again, and I'm making my paracentesis incision first on the right and then the left side, making sure the incision is flat to the iris plane, which makes a nice corneal shelf which will allow me to achieve a self-sealing incision. This is some intracameral lidocaine and then dispersive viscoelastic to fill the anterior chamber. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove tunnel, turn the eye towards me, and then I enter. Push some more viscoelastic to flatten the anterior capsule. Go in with the teeth sideways for the rhexis forceps. Puncture the center. You can see it doesn't want to really puncture, and that's the first sign. There's quite a bit of stria as I was trying to puncture. So this patient has a little bit of zonulopathy, and then I'm going to have to use a cystotome needle to create the rhexis here. So again with the cystotome, puncture the center, pull to the left, and then I'm going to pull down to create a little bit of a flap. So you can see the flap there. So I grab the right side of the flap, going around circumferentially, again trying to use a corneal mark that I made as a guide to help me center and size the rhexis. Otherwise, the capsular bag looks fairly stable. I don't see any stria as I'm pulling on the rhexis edge there. So this is the capsular fornix hydrodissection technique. I place the cannula under the rhexis edge, pointer tip down, get a nice wave, decompress on the left side, point the cannula tip down to the right, which hooks the peripheral lens and it spins nicely there. Irrigating the surface of the eye, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. As I do this, I'm mindful of the zonules, placing the chopper under the rhexis edge contra-incisionally, pointing the phaco tip vertically sub-incisionally, bisecting the lens in half, that's double chop, placing the chopper around the right heminucleus, pulling it centrally toward and against the phaco tip, which crushes the right heminucleus in half, that is cross chop. Using a little bit of vacuum to lift that first quadrant up, and then I'm emulsifying the lens piece, placing the chopper around the second quadrant, pulling it centrally, crushing it, and bisecting that piece in half, and using a little bit of vacuum to pull the pieces up, and then emulsifying the lens pieces. Just using the chopper to manipulate those pieces, and then emulsifying the lens. Rotating the second heminucleus in front of me, placing the chopper around the lens, and then pulling it centrally and crushing it against the phaco tip. Using some vacuum to grab that third quadrant, and then using mechanical forces to crush the lens piece into smaller pieces. Rotating the last quadrant, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, bisecting it, crushing it against the phaco tip. And then using mechanical fracturing forces to crush the pieces into smaller pieces, and then emulsifying the lens piece. Using some vacuum to remove the epinuclear material, making sure the phaco tip is deep to protect the posterior capsule. I take the chopper out, push BSS in, take the phaco tip out, and I'll go in with the INA handpiece. Starting sub-incision, I'm removing the cortical material, sweeping side to side a little bit, trying to get a clean peeling of the cortex off the capsular bag. Switch to polish mode, polishing under the rexus edge to remove lens epithelial cells. Polishing the posterior capsule as well. Pulsing BSS into the subincisional space. You see some lens material came flying out. Inflating the capsular bag with cohesive viscoelastic, and then polishing under the rexus edge with the sweep. First on the left side and then the right side. And then I'm going to widen the incision with the blade. Again, for denser lenses and with zonulopathy, I like to use 3-piece lens. I feel there's a stronger peripheral capsular bag support with that. So I went in and I could tell that it wasn't really wide enough. And so I'm going to widen the incision one more time. This particular blade doesn't really have great side cutting, and so it took a little bit more effort to cut that. I'm able to go in nicely. With the bevel pointed to the left, the leading haptic is delivered planar into the capsular bag. The optic is coming out sideways, so I have to rotate my wrist counterclockwise about 90 degrees. The optic comes out flat. The trailing haptic is dialed in with the Maltzman into the capsular bag. So I go in with irrigation off, activate irrigation, go underneath the lens, removing the viscoelastic from within the bag, and then in the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had a little bit of zonulopathy, which was found primarily during the rexus. I tried to use a forceps to puncture. It didn't puncture very well. There was quite a bit of zonular laxity. When that happens, it just makes you acutely aware and looking for, okay, what other signs of zonulopathy will there be during this case? Remember, if there's zonulopathy, that means the posterior capsule has a higher tendency to come up and get ruptured. Anytime you exert torsional stress on a capsular bag by spinning it, by sculpting on it, by pushing on it too much, you can exacerbate the zonulopathy. And I do think that's why some of these patients end up coming back years later with dislocated lenses. So the way we do cataract surgery by spinning the lens in the bag and spinning it, moving it, and manipulating the lens so much, I really think that can cause and exacerbate zonular damage and stress. And so you want to employ techniques like I've shown, where there's minimal stress on the zonules, a lot of forces that are pulled toward the center, away from the peripheral bag and zonules by hooking lens pieces, by using mechanical fracturing to crush the lens pieces, and very carefully emulsifying the pieces while protecting the posterior capsule with the chopper. So I hope this was helpful to you, and I thank you for your attention.